Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. David Brent will present Assessing and Managing Adolescent Suicidal Behavior, New Approaches. The Brain and Behavior Research Foundation funds the most innovative ideas in neuroscience and psychiatry to better understand the causes and develop new ways to treat brain and behavior disorders. These disorders include addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, obsessive-compulsive disorder, post-traumatic stress, and schizophrenia. Since 1987, the Foundation has awarded more than $418 million to fund more than 6,000 grants around the world. I'm delighted to introduce Dr. David Brent. Dr. Brent is Distinguished Professor of Psychiatry, Pediatrics, and Epidemiology, and Clinical and Translational Science, as well as the Endowed Chair in Suicide Studies at the University of Pittsburgh School of Medicine. He was a 2001 Distinguished Investigator Grantee and the 2006 Ruane Prize winner for Outstanding Achievement in Child and Adolescent Psychiatric Research. Today's webinar will begin with Dr. Brent's presentation. This will be followed by a question and answer period. To submit your questions, please use the question tab on the control panel on your screen. Please feel free to submit your questions at any time. Following the presentation, I'll ask as many as possible in the time allotted. And now, I'm pleased to introduce Dr. Brent. David, the floor is yours.
Thank you so much, and thank you for inviting me. Hopefully, I will be able to manage this okay. So today I would like to share with you some new approaches to the assessment and management of adolescent suicidal behavior. And I am very grateful for the support that I've had from the Brain and Behavior Foundation, as well as their recognition of our research. I would like to share with you some promising new developments that may help us reverse the disturbing trends in adolescent suicidal behavior. And so today I'd like to talk about four things. First, we're going to talk about the screening for suicide risk in pediatric EDs. Second, we're going to talk about the application of use of machine learning to electronic health records in order to delineate suicidal risk. And then talk about the application of machine learning to looking at fMRI neural signatures of suicidal people. And finally, to talk about how to generate a safety plan and an app that we've developed that looks like it is able to help protect high-risk youth against recurrent suicidal behavior. Then finally, I'm going to mention some evidence-based approaches that aren't really being used enough, but that, if deployed, could reduce the suicide rate as well. And so this is the story. I started working in 1980 in the problem of adolescent suicide. And by around the early 90s, we actually became pretty optimistic and had a long period of time where the rate declined. But as you can see, since the mid to early 2000s, the rate has been increasing. And if anything, it seems to be accelerating. We don't really know why, but clearly what it means is that what we are doing isn't working. And there are a number of challenges to the prevention of adolescent suicide. The first is that it's hard to predict, and that most at-risk patients present in emergency room or primary care, not in mental health settings. that our assessment relies heavily on self-report, and that youthful suicidal behavior is often impulsive, meaning that, for example, if you look at the steps involved in making a suicide attempt, the majority of them take place within 6 hours of the suicide attempt. And so the issue is whether or not we can detect inflections in suicidal behavior and provide just-in-time interventions triggered by those detections of inflections. So I'm going to talk about two major approaches to suicide prevention. One is I would term population health. And this is basically using tools that we already have, but in better ways. So it involves prediction and identification, particularly in primary care and emergency settings, and then providing an optimal match between needs and resources. The alternative approach, the complementary approach, is to focus on individual differences that contribute to suicidal risk. And this may involve alternatives to self-report, and these types of approaches are going to be much more sensitive to real-time fluctuations in suicidal risk and may potentially be able to lead to risk-triggered interventions. So let's first focus on pediatric EDs. And so why look there? So first of all, youth who come to EDs are at increased risk for suicide attempts. About 1 in 10 of those who die by suicide visited an ED within 2 weeks of their death. And many of the reasons why youth come to the ED are also risk factors for suicide: somatic complaints, chronic medical illness, assault, head injury, alcohol and drug intoxication, and the use of the ED for primary care purposes. All of these things increase youth's risk for suicidal behavior. In addition, a high proportion of youth visit the ED at least once a year. And in studies that have been done that have tried to screen for suicidal risk, between 1/3 and 1/2 of those who screened positive did not present with behavioral health concerns. So this justifies the role of screening. In addition, about half of youth who die by suicide, it's their first suicide attempt. Consequently, you really want to identify people before they make a suicide attempt. And again, a very low proportion of people who die by suicide are in treatment at the time of their death. In addition, there's room for improvement in emergency departments, so that one study showed that slightly under 40% of youth who had a documented suicide attempt received a psychiatric diagnosis. And we know from epidemiologic studies that between 80 to 90% of youthful suicide attempters have a diagnosis, so it suggests inadequate assessment and documentation. And just one other evidence that the care is not optimal is that in a different study, they showed that there's a very low rate of assessment of the ability of lethal agents and counseling about securing them. So these are two, very simple but very important facets to improving our care for suicidal youth seen in emergency settings. And there is evidence that brief screens can identify youth at high suicidal risk. The most commonly used measure is something called the ASQ5, 5 items. And it's been widely studied, and it's very sensitive, meaning that if you screen positive, you're at risk. But in one study, the specificity was quite low, meaning you have a lot of false positives. And in another one, while it showed high specificity, the sensitivity was low, which means you have a lot of false negatives. You don't really want a lot of either of those. So it seems like, although this is a promising beginning, we may be able to do better. And one other point is that screening alone, although it's important, without some follow-up that links patients to aftercare, really doesn't provide any quality improvement. So we're currently doing a study that's led by Cheryl King and Jackie Group Phelan and myself. And it's a study in 13 pediatric emergency rooms. And we've worked with Robert Gibbons, who's a statistician at University of Chicago, develop what is known as an adaptive screen. Adaptive screens are where you start with a very large bank of items, and then the questions that a person gets are conditional on their responses to the previous questions. So if you get a question like, are you aggressive? And the person answers no, they might get a different question than if they answer yes. And so because suicidal behavior is multidimensional, it allows you to get to the point much more quickly than, with a much larger battery that is incompatible with the pace of emergency departments. And so our preliminary work thus far in a prospective study of 2,000 adolescents, and just recently we replicated it in another prospective sample of twice that size, is that a 6 to 11 item screen can predict a suicide attempt within 3 months with very high accuracy, both good specificity and sensitivity. So just to conclude about emergency rooms and why I think this is a promising area, it's a good place to screen because, first of all, many high-risk youth go there. And the second is that many who are at risk for suicide don't present as suicidal, but are screened positive if examined. And there's also room for improvement in the management in these settings. And so the point is that screening, especially in concert with some brief intervention that can link somebody to treatment resources, we believe can make a difference in reducing the rate of suicide attempts. The second thing I'd like to speak about is machine learning of electronic health records. And these are pictures of my colleagues, except for the middle one. So Neil Ryan is a child psychiatrist who works closely with me, and Rich Su is a bioinformatician, and Candace Bernicer is a postdoc who works with us. And we applied machine learning to a set of electronic health records. So first of all, I think AI and machine learning, people are becoming more and more familiar with it, but basically machine learning is where the program is able to modify itself through feedback, which is designed to improve further performance. And machine learning has some advantages over some of our standard statistical approaches, because if you take a large number of variables and they're somewhat intercorrelated with one another, our standard approaches don't work, but that's really what the data sets that we have to work with look like. And where you have many variables, each of which makes a small contribution to risk. Now, there are disadvantages to machine learning, which is that the more powerful the technique, the more opaque. In other words, it's hard to explain why somebody was flagged. And so right now, machine learning is better for identification than in understanding etiology. The best done study, in my opinion, is one by Greg Simon. This was a study in about 3 million patients, and they were able to predict a suicide or suicide attempt within 90 days of the last clinical contact. And another way to think about it is they were able to identify close to half of the suicides scored in the top 5 percentile of their risk score. And in this particular study, they focused on those with a mental health diagnosis. And since we know that most people who die by suicide don't have a mental health formal mental health diagnosis, while this is very promising, we need similar algorithms that would inform us about people who haven't received such a diagnosis. And there's a complementary approach called natural language processing, which basically identifies words and strings of words that are associated with a particular category. And so NLP, natural language processing for short, can do a couple of things. One is that since we know that charts are not always accurate, and that there may be some suicide attempters who, where for whatever reason the clinician didn't document it in terms of a diagnosis, but yet you can find evidence of a suicide attempt in the clinical note, then this helps us improve the accuracy. And in fact, it turns out that there's considerable under-ascertainment based on the diagnoses alone. But I think an even more promising area is that you can extract data from the clinical notes, social determinants of health. And in this one study, Dr. McCoy was able to identify hopeful phrases used by the clinician. And the more hopeful the phrases, the more protective, the lower the risk for eventual suicide. So this is a powerful tool that is complementary to standard machine learning. And in a study that we have that's still ongoing, we obtained records from our health system, and we did a case control study where we matched individuals with a history of a suicide attempt to those who had no suicide attempt or death. And we tried 8 different types of machine learning with time windows ranging from 7 to 730 days. We developed the algorithm on 70% of the sample and then tested it on the last 30%. And we found one form of the of machine learning that also included natural language processing. We were able to identify with very high accuracy a suicide attempt within 7 days of the last clinical contact. And we also stratified the sample by sex, age, whether or not they had public or private insurance, where they were seen, race, and clinical diagnosis of depression. And pretty much the algorithm was robust to all these stratifications. So we believe that this is quite a promising approach. And you can see on the right-hand side that kind of the variables that come up from the clinical charts. For example, tattoo was something that you might not find in a diagnosis, but it was a risk factor for suicide attempt. And you can also see that it identifies factors that are protective against suicidal behavior. So we can conclude that machine learning can result in accurate predictions of suicide attempts within a narrow time window, and that natural language processing adds to the accuracy of prediction above and beyond structured data. And in our case, the algorithm was robust to point of service diagnosis and demographics. There are some other considerations, though. For example, in our study, patients may have had visits in other health systems. We are limited by the accuracy of diagnostic coding. And I think this third one is a critical one, that if there are healthcare biases in terms of access, the algorithm could reflect or even exacerbate these biases. And there are ways to check on that, but it's important to consider that. The more complicated the algorithm, the more opaque, and therefore we have to figure out how are we going to explain to a clinician or a patient why a particular person was flagged at high risk. And so we're currently doing a qualitative research with clinicians, patients, administrators, and ethicists about the best way to apply these algorithms. I'd like to now shift to another topic, and the folks here all made very important contributions to this study. So Marcel Just is a cognitive neuroscientist at Carnegie Mellon, which is really right next to University of Pittsburgh. And he, much of his work is on the neurobiology of language. And I heard him give a lecture at our institution, and he talked about trying to differentiate people with autism from people who are neurotypical. And he had them think about words related to relationships, and then looked at the activation patterns in the autistic and neurotypical individuals, and then used machine learning to see if using these activation patterns, he could separate the two groups. And he could almost completely. And so I went up to him, asked afterwards, and I asked him if he was interested in studying suicide, and he was. And so then I engaged Matt Nock and Christine Cha. Christine is a very promising young suicide researcher. Matt is still pretty young, but I would have to say he's probably the smartest suicide researcher in the country. A wonderful person as well, but really, and so we went to them because they had developed a different cognitive test using different words related to suicide and negative and positive emotions. And so we took their words and adapted it to the task that Marcel uses in the scanner. Dana McMakin is a clinical neuroscientist, as is Lisa Pan, who helped with the development of the protocol. And Lisa actually was very involved in recruitment and management of the subjects while they were being studied. And so what we did is we compared 17 young adults with suicidal ideation and 17 healthy controls. We had a second sample of 34 participants. We had them think about 30 words, 10 related to suicide, 10 with positive emotional valence, and 10 with negative emotional valence, and then use machine learning to discriminate activation patterns. And we wanted to see, first of all, could we discriminate ideators from controls? And could we also identify which ideators had a history of an attempt and whether there were distinct emotional component signatures that discriminate between the groups? And this is the list of the words. I think you can see that the words related to suicide, like death, fatal, funeral, overdose, suicide, are, there's a lot of face validity for those choices. And it turns out that we were able to sharply discriminate ideators from controls. And the words weren't all that helped in the differentiation weren't all related to suicide, although the single best discriminator was the word death. And, it's a very small sample, but we did various things to like leaving one out or looking at half of the sample. And, the algorithm still performed well. And the brain areas that were involved that were differentially activated are brain areas that are related to self-reference. And it turns out that if you debrief, which we did, the ideators after they finished their time in the scanner, and we asked them what they thought about when they thought about each word. It was very common if they came to the word funeral for them to say my funeral, whereas the controls didn't think about things so personally. And it turns out that this self-referential thinking is a very strong finding if you look at the language of suicidal people. And we were also able to differentiate those ideators with a history of an attempt from those without such a history. Similar words, and it basically the same findings, but stronger. I don't think I have a slide to show this, but Marcel is able to extract the emotions that people are experiencing using machine learning while they're thinking about different words. And the thing that differentiated the attempters and non-attempter ideators, for example, when they thought about death, the ideators without a history of attempt experienced a lot of distress, whereas those who had already made a suicide attempt did not experience that much distress when they talk about death. It's kind of a scary finding, but if you think about it, it makes sense that somebody who would actually engage in a suicide attempt is less concerned about dying than somebody who has thought about suicide but hasn't done so. And we also found that if you looked at the degree of alteration of the activation patterns from the controls, that was correlated with the severity of suicidal ideation in a cross-sectional study. And this just gives you an idea of the comparison between the ideators and the with and without an attempt, and that there was a fairly sharp demarcation between the two groups. And this shows the brain regions that are differentially activated, for the most part, midline areas that are involved in different aspects of self-concept. Now, there are a lot of limitations of the study, of course. It was a small sample. They had a high IQ. A lot of them were college students. It was mostly female, and it's dependent on people paying attention. In this study, we didn't have any psychiatric controls, so we just had healthy people, but we were able to identify ideators with and without an attempt, and it was cross-sectional. We did then take this algorithm and use it on another 34 people, and it performed well. So we believe that this, this is a promising approach. And we now, I'm not sure if we have a slide. Yeah, we now have a larger study from the NIMH to study people prospectively and to have them go in the scanner twice and then see whether there are any changes in their activation patterns, whether that reflects changes in their degree of suicidal ideation, and whether or not we can predict suicide attempts. Where we'd like to go with this work is to be able to develop some techniques where the person can get feedback about their thinking patterns in real time that can then more accurately guide psychotherapy and help, thereby helping patients to conceptualize things like death and suicide in ways that are, decrease the likelihood that they're going to make a suicide attempt. So I'd now like to switch to talk about safety planning and describe the approach that you take to generating a safety plan, and then talk about an app that we've developed that supports safety planning in adolescents. So first of all, a safety plan is a structured set of responses that's designed to help the suicidal patient cope successfully with suicidal urges. Basically, what we're trying to do is prevent the progression from urge to action. And since suicidal acts represent an imbalance between distress and restraint, what safety plans should do is improve distress tolerance, reduce distress, or improve restraint. And because youth suicidal behavior is so impulsive, it's really important to teach them how to catch emotional distress before it becomes a crisis and they're no longer able to rationally use a safety plan. And so this is a pretty simple model of suicidal risk. Some of the things that, increase distress would be things like mental pain, agitation, insomnia. And there are also things that would increase restraints, so sobriety, safe storage of lethal agents. And basically your safety plan, as well as your treatment plan, really is trying to tilt the balance in a way where you increase restraint and you decrease stress. So the first step is that you want to identify what are the triggers for suicidal behavior for that person. And they can be events, they can be emotions, they can be behaviors, or a combination of them. And so the way you would get into this is you want to know what happened that led you to want to make a suicide attempt. And some of the things that you may want to pursue are things like, change in stress level, traumatic events, insomnia, intoxication, sexual or general minority issues, or peer victimization. These are common contributors to suicidal risk in this population. And then the next thing you want to do is see if there's anything you can do to avoid these triggers, which isn't always possible. But for example, if there's a lot of interpersonal discord and that's a precipitant, then you may want to see if you can get the person to avoid that person or get an agreement between, say, a parent and a child to table the discussion of hot issues until they've progressed in therapy. Another example would be where a kid is being cyber victimized, and you could block the people who are posting hurtful comments. You can try and deal with vulnerability factors like poor sleep or alcohol and drug use, which often is there's not a quick fix to that, but you can certainly make the environment safe in terms of locking up sharps, medications, chemicals, and weapons. Now, in addition to trying to avoid the trigger, which isn't always possible, you want to try and help somebody cope with the trigger. And so you want to know what's worked before, and some common approaches are self-talk or distraction, relaxation or meditation, reviewing reasons for living, and basically to start with, you want somebody to pick one skill and practice it. I'm going to talk about the emotional thermometer next, I think. So remember that I said that adolescents often have a very short period of time from the crisis to engaging in suicidal behavior. And so we teach kids to rate their emotional temperature and ask them, like, if 10 is out of control and 0 is calm and in control, what's the level that's the hottest for you that you can get and still turn around? So if a kid says a 6, then we would say, well, let's talk about a 4 then. How do we know when you're there or at that point or just before? And, what are the physiologic indicators? How do you know you're there? And then come up with coping strategies for lowering the temperature, and try and get the kid to practice on a daily basis in rating themselves and practicing these coping skills. So a second level, these are things that you can do by yourself, but then there are interpersonal coping resources. And in the adolescent age group, we try to emphasize that it's okay to reach out to peers as distractors, but that they shouldn't be used as therapists. Adults can provide support, but they're going to want to direct the youth to professional help. And before you do that, you want to get parental permission, as well as permission from the parents of kids to be included on this list. Then the next level, if that doesn't work, are clinical and crisis contacts. And so that would be a therapist. And depending on the therapist, there's ground rules about when you can call, who's going to be available. And you need to pick a balance between being available for coaching, but you also want to promote the patient's autonomy and not reinforce suicidal behavior. There are crisis lines. There's a crisis line. And then there are, mental health crisis services, which are locally determined, the police, and, going to an emergency room. So all of those are the kind of last line of defense. After you've worked this out with the kid, you then bring the parent in and ask the kid to explain to the parents what the safety plan looks like, and have them give an example of a trigger and how the patient would use the coping plan. Then you want to get parental feedback about what they think would work or not work. If they need a truce, this is the time to do it. You have to talk with the parents about a balance between the fact that they're really freaked out that their kid has, been cutting or engaging in some kind of suicidal behavior versus, not giving the kid any space at all. You want to ask both of them after you've gone over the plan, how confident are they that they could use it, what might affect in one way or another the likelihood that they'd use it, and what kind of things might get in the way of them using it, which may lead to a modification of the plan. And finally, you need to go, the parents are the ones that are going to be in control of the lethal agents and securing them, and you want to get their buy-in for that. Now, sometimes you have people that don't want to agree to use a safety plan. So one category that isn't actually so much of a problem are these scrupulously honest kids who say they can't promise 100%. And so you ask them, well, what percentage can you assure us? And you can also try and reduce the time window for the safety plan and ask what might increase the likelihood that they could adhere to it. You also have kids that are super oppositional, and so again, there you might want to negotiate for them to use some components or a more restricted time window. And then the third category are kids that are in a lot of distress, either due to high environmental distress or their own mental impairments. And those are kids that probably need to be hospitalized or removed from the home, and where a safety plan is not likely to work. So just to review, a safety plan involves 5 steps. You want to orient the patient to safety planning, explain what it is and the rationale, identify the triggers, make the environment safe and avoiding triggers, developing coping strategies, which include emotional thermometer and some of these other intrapersonal and interpersonal coping strategies, and then review with the family and identify potential barriers and problem solve around that. So now I'd like to share a study that we've been involved in with a suicide prevention app. And these are some of my colleagues who've been involved in this work. Betsy Kennard, who's at University of Texas Southwest in Dallas. Candace Bernicer, who's a postdoc and was also involved in this other study. Jamie Zelazny, who's in the School of Nursing. Tina Goldstein, who's a terrific psychologist interested in youth suicidal behavior, and Stephanie Stepp, who's a psychologist interested in the interfamilial transmission of emotional dysregulation. And so just a little bit of data about safety planning. There are 2 very good studies that have shown the effect of safety planning. In one study by Craig Bryant, they called it a crisis response plan, but they randomized people to get that or usual care. And, really cut the suicide attempt rate, it's a fourth of what it would be with treatment as usual. In a much larger study, Barbara Stanley and Greg Brown in adults in emergency rooms showed a more modest effect, but they only, got the information through medical records. And whereas in Craig's study, the intervention was delivered by, research personnel. In Barbara Stanley's study, they were the individuals in the ED. But still, they made a substantial difference in the suicide attempt rate. Now, one of the reasons we started thinking about developing an app for safety planning is that this way the safety plan would be available to the person in real time. And so also, given that many youth at high risk present in settings other than with specially trained mental health practitioners, if you could modify the app so that it could lead a clinician step by step through building a safety plan, then this could increase our use of safety planning beyond those who are specially trained. In focus groups with teenagers, when we asked them what they wanted security, they wanted discretion. They didn't want an app that, said, suicide prevention app that anybody could see. They wanted to be able to personalize it. They wanted suggestions for useful interventions. And they wanted multiple methods of coping so that if one didn't work, they could try a second. And they also wanted daily reminders to use the app so that when a crisis came, they were used to using it. Now, there are other apps in the, that have been tried. iBobbly is a study that was an app that was developed in Australia for Aboriginal youth. And it's really more of a cognitive behavior therapy that's very culturally appropriate, and it did reduce stress and depression, but not ideation or behavior. Another app is the Virtual Hope Kit, which has reasons for living presented in pictorial form. And in a pretty sizable study, they showed that they were able to improve their self-rated efficacy for coping, but they didn't demonstrate any effect on distress or suicidality. Blue Ice is one in England, which looks promising in open trials, but it hasn't been tested in a clinical trial. And our app, Bright, and the variations thereof, to our knowledge, it's the only app that's been tested in adolescents with an RCT that had a suicide attempt as the primary outcome. And so this is the team that was involved in that. You've met some of the people, but also Antoine Douay, who was an expert on motivational interviewing, and Dana McMayton, who you met in the machine learning study of imaging. But Dana also is very interested in positive affect, and so she helped develop one of the interventions that we used here. So we focused on kids who were hospitalized for a suicide attempt. And the reason is that if you look at the risk of suicidal individuals being discharged from the hospital, their risk for suicide is about 100 times higher than it is for the population. So this is a very, very high risk group. And we had a complementary experience where we were running a clinical trial for an intervention for suicidal behavior. And we found that many of whom were in the inpatient unit, and we found that a lot of individuals had suicidal events within the first 4 weeks of treatment, kind of before the treatment could take effect. So we thought, if you put these two ideas together, that we ought to move upstream and try and deliver something on the inpatient unit, which then would kind of inoculate the kid until the treatment that we were delivering outpatient could begin to take effect. And so we developed an intervention called As Safe as Possible, or ASAP. And so treatment as usual on the inpatient unit has some skills groups, a standard safety plan, and some aftercare plan. And in addition, we did a chain analysis, which is a detailed behavioral analysis of the things leading up to a suicide attempt. We generated a safety plan. We focused a lot on distress tolerance and emotion regulation. And we used motivational interviewing techniques to encourage people to use the plan, and also outpatient follow-up. And in addition, we developed an app called Bright. I don't particularly like the name, but the kids did, and so that's why we used it. And so this is the first prototype, the one that we used in the study. And so you can see they get a daily dose to rate their distress. And then depending on where their distress level is, it could take them to, crisis mode, to looking at reasons for living, or, positive memories. And, over time, the app individualizes and tunnels the person depending on their level of distress to a subset of these interventions. And so, in Dallas and Pittsburgh, we did a 2-site study where we took 66 suicidal youth hospitalized for suicidality, and we randomized them to ASAP with the Bright app, or treatment as usual. And ASAP was about 2.5 hours on the inpatient unit. And then we developed a safety plan and loaded the app on their phone. And at 6 months, the rate of suicide attempts in our treatment was half of what it was in the treatment as usual group, although it wasn't statistically significant. Although it was significant in the subset it had a previous history of an attempt. And we also found that the more frequently that they used the app, the greater the reduction in suicidal ideation and the greater the increase in reasons for living. So 70% of them used the app at least once, and on average, they used it about 30 times. But it was mostly in the first month post-discharge. And this is some of the feedback we got, kids saying, I really liked it. It helped. I began to do the techniques even without the app. It became natural to me. This kid found it was helpful for dealing with anxiety and sleep. The kid liked the fact that there was a lot of diversity. They liked the focus on reasons for living, and that it was helpful in the moment. And in fact, it helped them to look beyond the moment. And so on the basis of our results and the qualitative feedback, we redesigned Bright, and we're now testing it in a much larger clinical trial of inpatients, looking at the app alone, the inpatient intervention alone, the combination, or treatment as usual. And the formatting is really based on the feedback that we got from the kids. And I think you can see here, I think you can see this arrow, but this little lifesaver, that activates the crisis plan, so that's on every screenshot. Now, we also modified this to develop something called Guide to Bright, and which basically leads the clinician step by step through the development of a safety plan. So first, it explains what a safety plan is, helps them set up the emotion thermometer, pick some different techniques, and puts in reason for living, developing the safety plan, and then showing the kid how to personalize things. And again, just picking a selective number of things to personalize, but showing the kid how they can do it, and they can continue to modify it in the future. These are just some of the other activities that they could use. And so we think that this could have a high population health impact, because it could decrease suicide attempts in high-risk youth and potentially decrease unnecessary readmissions and visits to the ED. In a large enough population, you could perhaps detect a reduction in the rate of suicide, and it would also increase the pool of clinicians capable of making a competent safety plan. And this Zoom link will take you to a demonstration of the app if you're interested in that. And we're currently negotiating with our university to be able to release this more broadly, but there are some legal issues that we have to resolve in terms of liability before we can do that. But that is our goal. So I just wanted to just add a couple of things, that there are evidence-based methods for reducing suicidal behavior, so that, all isn't lost, but we don't really use them enough. And the categories fall into something called the good behavior game, which is something that's given to kids who are in first grade to teach them basically how to follow the classroom rules and diminish aggression. The Youth Awareness of Mental Health is a curriculum that helps kids to identify suicidal risk and depression in themselves and in others, and how to respond. The family checkup is something that augments parental resilience. So it improves parenting, parental monitoring, and things like that, and has been shown to decrease suicide attempts. And there also is evidence of improved quality and coordination of care can reduce the suicide rate. And finally, restriction of access to lethal agents. And if these things were all implemented, you probably could reduce the suicide rate by between 20 and 40%. And so this shows the good behavior game's impact. This is a follow-up of kids that are now in their 30s who received the intervention 25 years previously. And you can see that they have about half the rate of suicidal ideation and attempts. This is from a study, the YAM study, and it was a school-based intervention for high school students, and it compared gatekeeper training, screening and referral, a control condition, and YAM, which is the curriculum. And YAM was the only one compared to controls that reduced the rate of suicide attempts and ideation. These are just examples of family interventions that improve family resilience and can reduce suicidal ideation and attempts in pretty long-term follow-up. And this is a study from Korea where after banning paraquat, which is an insecticide that's fatal in ingestion, and showing a significant drop in the suicide rate. And finally, it's possible to change, to improve clinical care within a system. And this was done at Henry Ford Hospital, which is in Detroit, not surprisingly. And they embarked on a quality improvement campaign that an advisory group. They trained people in CBT and assessment of suicide risk, improve access to care, became more aggressive in following up people that are not adherent, removal of lethal agents, and they were actually able to reduce the suicide rate among mental health patients substantially. In fact, down to 0 over a 10-year period, although in further follow-up it's gone up, but it's still a fourth of what it was before. So this can definitely be done. It's a matter of the commitment of a given health system. So in conclusion, there are some promising new ways forward, and fanaticism is the belief that if we keep doing the same thing, we'll get a different result. And we've been doing that now and watching the rate go up. Or we could try new things, such as screening in an ED paired with an intervention, the application of machine learning of health records in order to identify people at high risk. I didn't really talk about that, but there are ways to identify people at high risk on the basis of natural language processing of social media posts, and you could have a social media triggered intervention. We might someday be able to develop neurofeedback to help people change the way that they think about death and suicide to a more adaptive way, and the use of safety planning apps for high-risk individuals. And I think that concludes my remarks, and if there's time for questions, I'd be happy to take them.
David, thank you for just an outstanding presentation that brings a lot of information to bear and a lot of actionable information that could really have an effect on this important issue. You, at the beginning, spoke about the increase in suicide in this population over this more recent period of time. What do you see as the potential causes of that increase rate?
I don't know. I was asked to be on, I don't know, some big news show to talk about that because the CDC, released some disturbing statistics. And I said, well, I can save you time. I said, I don't know. I don't think I'd be a very interesting person to interview. People say, social media, but the data are very confusing on that. And we've actually done some studies that show that kids who use social media get more social support in some cases. I just don't know. We're trying to design studies where we can try and address that, but it's really a mystery to me about why it's happening.
Well, thank you for answering that so directly. I guess if you knew that would, if we had the real answer to that, that would be on the front page of the New York Times.
Or if somebody said that they had the true answer to that.
Right. One of the things that people are often concerned about is the belief that asking about suicide can give somebody the idea and increase the risk, when the reality is often asking about it can ultimately save a life. And I'd like you to speak toward that issue.
Right. That is a great question, a very important issue. And Madeline Gould actually did a really classic study, I think in 2005. She published it in JAMA. She took kids and randomized them to either get an assessment of risk factors but not ask about suicidal risk, or those risk factors plus ask about suicidal risk. And then she followed them up and showed that there was no difference in the suicide attempt rate, and that actually the kids who were asked about suicidal risk, the ideation questions, experienced less distress over time than the kids who weren't asked. So aside from the fact that from a common sense point of view, it makes sense to ask, she actually demonstrated that it doesn't increase risk at all.
Very important point. One last question. Given the fact that so many young people who die as a result of suicide really had no prior suicide acts, and it often, sadly, we hear the story, it's a total surprise to the family that this could happen. What types of steps should any parent take with regards to this issue, and trying to decrease the risk that such a tragedy could occur?
So there are a couple of things. If you know that there are risk factors in your family, then you should have a low threshold for getting help for your kid. You know, in other words, if you have an anxiety disorder or a bipolar disorder or whatever, then you should have a low threshold for getting help. And the same if a kid is having trouble functionally impaired, difficulty socially, difficulty academically, then it's likely that there's some kind of mental health component that's going on, and so they should be assessed. But even in kids that are healthy, there are things that families can do, simple things. So family meals. I mean, there are studies that if you eat dinner with your kids every night or frequently, they're at about half the risk of a whole range of health risk behaviors, not just suicide. And there are other, parenting practices that people can learn, and I actually think should be part of well child care, that can augment, that can make families more resilient, and protect them not just against suicide, but substance abuse, risky sexual behavior, all the things that keep parents up late at night. So I would say things like making sure that your family, you know how to monitor your kids, your discipline is consistent, and that you have a positive relationship with your child such that he or she can come to you if they're concerned, and vice versa. Those are, very, very important elements of a healthy family. And, it's a lot harder to do than it sounds. So there's no crime in admitting that you need help in learning how to be a better parent.
I think, all excellent advice. And I just want to thank you for your ongoing work on this important topic, and thank you for joining us today to share this extremely important information. I also want to thank everybody for joining us today. 100% of all donor contributions for research are invested in our grants to scientists. All the research we fund is made possible through supporters like you. So please consider making a gift by visiting our website, bbrfoundation.org, or calling 1-800-829-8289. This webinar has been recorded. If you missed any portion or would like to share it with family or friends, please visit the events and webinar page on our website. I hope you'll join us again next month when Dr. Carrie Ferrario, Associate Professor in the Department of Pharmacology at the University of Michigan Medical School, will present Why Did I Eat That? Obesity and the Neuroscience of Food Craving. This webinar will take place on Tuesday, October 13th at 2 p.m. Eastern Time. I'm also pleased to let you know that the BBRF International Mental Health Research Symposium will be held digitally this year. Please join us for exciting virtual scientific presentations on innovative brain and behavior research, which is being conducted by our 2020 Outstanding Achievement Prize winners and a Partis Humanitarian Prize winner. All presentations will be available for streaming in any order you wish to watch at your convenience, beginning Friday, October 30th. Please visit our website, bbrfoundation.org, for more information. The registration link will be posted shortly. Until next month, I want to again thank you for joining us and thank you for your support. Take care.